Hello, and welcome to the BCN and Friends podcast, where we have real conversations about learning, leadership, and the lived experiences of nurses and healthcare professionals across the emergency spectrum. Each episode, we sit down with thought leaders, BCN certification holders, and industry experts who share their stories, their insights, and the challenges that shape their work. Our mission is simple: to amplify the voices of those making a difference every day, because your experiences drive progress, inspire others, and shape the future of nursing. We're here to honor that in every episode. Sometimes funny, sometimes serious, and always valuable. This is BCN and Friends, and we're so glad you're here.
In this episode, we're joined by Brady Bielewicz, an advanced practice clinician serving in a blended acute care NP and CNS role. Brady brings a unique perspective on trauma care, interdisciplinary collaboration, and the critical nursing assessments and interventions that truly impact patient outcomes. This episode is called Be the Change When Seconds Matter: The Power of Nursing in Trauma Care.
I'm Holly Briggs, a professional development specialist at BCN and one of your hosts for today. I'm joined by my co-host, Michael Dexter, our Director of Professional Development. Hi, Michael.
Hello, Holly.
In this episode, we're joined by Brady Bielewicz. I've had the pleasure of getting to know Brady over the last few years through his volunteer work with BCN, and I'm excited to kind of have this deep dive with him on the podcast. So, Michael, could you please introduce us to our BCN friend, Brady?
Yeah, absolutely. Brady, it's great to have you with us, and I am really excited to get to chat with you. But before we do, let's let the audience know a little bit more about you. Brady has a doctorate degree in nursing. So Dr. Brady Bielewicz is a trauma ICU advanced practice nurse, assistant professor at the University of Pittsburgh School of Nursing. With nearly 15 years of hands-on critical care experience as both an acute care nurse practitioner and clinical nurse specialist, he brings a real-world perspective that resonates with bedside nurses and advanced practice registered nurses alike. His work centers on trauma education, developing confident advanced practice nurses, and shaping certification exams that truly reflect clinical practice. Brady, welcome to the BCN and Friends podcast. It's a pleasure to have you with us.
Thanks, Michael. Thanks, Holly. Happy to be here.
Before we get too far into some deep clinical dives, also like into this whole clinical nurse specialist trauma, we've got a lot to talk about here. But before we get into that, we kind of want to give a little bit of background on what initially drew you to nursing and kind of what then not only got you into nursing, but then you decided to advance into the role that you're in now, going into advanced practice nursing. So what got you here, and then what kind of propelled you forward?
Gosh, what got me here? Well, I will definitely say in life, I think I've taken the scenic route, but I would say I also feel like I'm truly meant to be where I'm supposed to be, which is an amazing feeling that I'm lucky to have. But I think I always knew I wanted to work in healthcare. I can think back to seventh grade was like our first real book report, and I did it on an emergency medicine physician. So I think maybe that was my initial trauma spark there. And I think like a lot of nurses initially was like, I'm going to be the biology degree that goes to medical school. And once I really started diving into the pathways of medicine, I was like, I don't really see the work-life balance, and where's like the patient care aspect kind of a deal. And then I would say I fell backwards into nursing. I finished my undergraduate degree in biology, kind of took a year to find myself more or less, and happened to start looking into our hospital-based nursing programs. And I would guess the rest is history from there, you know? I did the program there. I thought I was going to be a nurse scientist, use my biology degree. And then I wasn't 5 minutes into my first clinical experience when I was like, no, this is where I'm meant to be, caring for patients, helping them through their day, you know, the routine of medication paths and charting, sure, but just being there and helping as part of their recovery it just felt so meaningful to me. As far as the advancing my education from there, it was just always the desire to learn more, the why to the what we were doing. Why were we choosing this medication? Why did we choose this procedure? Well, how did we know they had that diagnosis? Well, I want to be able to read the CT scan too. And then I think I can handle being an active part of this team and not just providing the care, but also making the decisions for the patients as well.
Well, Brady, we mentioned the CNS role and then also the acute care nurse practitioner role. Could you just briefly speak to the variances between those? And out of curiosity, which one did you jump into first?
Sure. So, ironically enough, I started in the nurse practitioner role. And then as I was working myself through that, I was kind of like, I don't know if this is totally me. I enjoyed the diagnosis, the ordering, the patient care. I'm like, but I want to make more of an impact. So that's when I kind of shifted gears to the advanced practice nursing role of a clinical nurse specialist that has the three spheres of influence, looking at the patient and family, the nurse, and then systems improvement too. Like I felt like I was that investigator of, how do we decrease our door to scan time? How do we decrease our hospital acquired pressure injury rate? How can we make a better bundle for central line care? Those were things I kind of did as a bedside nurse. And I was like, I could do this more at aside from just a unit based level, but maybe a hospital or even systems based change. That is where my DNP came into play. And here in my state of Pennsylvania, my scope was limited to that of a registered nurse. So I could make some of these impacts, but unfortunately, there was a lot of my scope that was still left to be had, shall we say. So I took a step away from trauma care for a bit, actually, and I started working in West Virginia in a CT surgery or cardiothoracic surgery vascular cardiology unit. Whereas a clinical nurse specialist, I had the best of both worlds because of how their state licensure went. So I was able to be a direct care provider and do all of those things. But then I also was able to sit in on division meetings and unit based interventions to talk about protocols, policies, procedures, and basically use my nurse practitioner skill set out on the floor or direct patient care skill set. And then on the other side, still have that clinical nurse specialist background. Then I knew I wanted to practice again back in Pennsylvania, got my postmaster's certificate, and then I was lucky enough to come back to work in the same unit I was a bedside nurse in. So I feel like I've been able to maintain that continuum of knowing my attendings, my surgeons, the teams, the processes and procedures, and then I'm able to on in this day blend both of those roles in operating on both APRN pillars, shall we say.
That's really awesome. It's great that you have that opportunity to do that and have worked in that capacity because I think a lot of newer nurses come into healthcare and they become a little bit overwhelmed at the number of specialties. And there's, even a joke in some parts of medicine talking about if you have a left ear pain, you need to call a left ear doctor. Like, it's become so specialized and so subspecialized that people often don't know where to look. And so now, on the nursing side, we have clinical nurse specialists, clinical nurse leaders, nurse practitioners, but then there's acute care nurse practitioners, family nurse
Mhm.
all of these different things. So, as a nurse that's maybe practicing in like a high acuity environment or some sort of clinical environment where there's a lot of various specialties involved, how do you really work with them to understand who is the best resource for what, like, and when to call certain ones, when to call the clinical nurse specialist or the nurse practitioner or the physician if there's different options available. And then, on top of that, if you were to start your own hospital tomorrow and create like your own model of where would all of these pieces land? You clearly see a need for the CNS role and the nurse practitioner role. But how do you see all of this collaboration working together when it just seems like there's so many broad specialties now and there's so many different ranges of medicine that at what point is too much and at what point does it become confusing versus helpful?
Yes, I think that is, I mean, even practicing in the role, I think sometimes I have to take a step back myself and be like, who is my next step in the chain of command here? I think my biggest thing is so in the intensive care unit, we round at the bedside every morning. And, my goal is that we have nurse led rounds, meaning that one of the providers kind of gives a one liner on, this is John Doe. He's an X-year-old male admitted after XYZ. And then the nurse gives their full head to toe report. So it's starting at that incorporation of them because we truly do value their assessment because they are the ones at the bedside not only signing off to each other, but for that 12-hour span, really learning the ins and outs of these patients and the nuances that they may have. But then also, when we have that multidisciplinary care discussion to decide that plan for the day, is that when we finish rounds, before we move to the next patient, is kind of hitting the pause button and then doing a little bit of summary. So basically, like for today, for John Doe, for this medical problem, this is what we're doing. For this medical problem, this is what we're doing. And then, as everywhere, we have our checklist of our A, B, C, D, E, F bundle. But to me, it's that end cap of like, okay, Holly, do you understand that for the next 12 hours, this is what we're doing for John Doe? And if not, like that's the initial time to say like, hey, I have a question. Like you said this, but maybe this isn't connecting. But then also there's a clear expectation from everyone on the team. So everyone there listening that, if Holly calls us about bed 7, we say, okay, well, this is what we went over today. As far as who to call next, I try to say for us is on the critical care medicine side that we always want to be kind of the first point of contact. So then we can try to understand what the nurse's concern is. And then maybe it's something that I can manage that we don't need to call the specialist. Or maybe this is something that, there's a significant neuro change and the patient had a head bleed that we want to let neurosurgery know because we might be going for a CT scan. That also is kind of a mutual level of respect that I try to maintain, that if especially if say neurosurgery is primary on that patient, they should be aware of what's happening. But also if we pull in a consult because we want their expertise, I want to make sure that we always utilize them. Not I'm going to consult them and have them write up a bunch of stuff because I think it's just the right thing to do, but disregard what they have to say. I think it's very important that we always respect each other's professional expertise and boundaries and find a way to stay on the same page. But either way, it's communication, right? If you're concerned, I don't care how minute it may be to anyone on the team, I would rather be aware than not at all. Like, hey, just want to let you know the patient's having a couple PVCs. Like that way, that's already starting a trigger in my mind that if I have heart rate issues down the line, they were already having PVCs, or their neuro change is a little off. Their strength was a 4 out of 5 in that right upper extremity. Now it's a 2 to 3 out of 5, or they seem a little clumsy. That way we can, I think it's so much better to treat proactively without over treating, obviously, instead of now their arm is a 0 out of 5. We got it. We may have a bigger problem here. As far as if I was opening my own hospital tomorrow, I do think a chain of command is important no matter what role you're in, because you want to know who you can go to with questions and who your resources are. But I think especially with the acute care population, the dynamics can change so quickly that there has to be some fluidity in that as well. If I'm not available as a nurse practitioner, but the physician is there, great. If the physician's not there, or, but they can come to me, and there's even some things within my scope that I have to escalate, but I can also get treatment started before, if I need some time until they can get there.
All of that, what I heard was communication, respect, following a chain, but also be willing to navigate that and approach it with the flexibility that's needed to take care of the patient. Because when I think about like the collaboration, it's we all have the same goal, right? Like we all are trying to do the same thing, which is give good care, great care to patients and have them be discharged home to their families and return to a quality of life that they can then continue to live outside of the hospital. And so I think when that is the goal, then everything else, as long as like you keep that at the middle, I think then it kind of frees people up to lose a little bit of like that defensiveness, or almost like I have to make sure that people understand that I am an important member of this team. And it's like, no, we all respect one another. We all communicate with one another. We're here working for the same goal. Like it just kind of removes some of that ego out, and it really helps to create that cohesive, that collaborative part. I think it's amazing that the nursing healthcare profession et cetera, has been able to expand their scope and has been able to step into places that maybe nurses traditionally 100 years ago would have never really been kind of welcome into, or at least not given like that role or that title necessarily. So I think that's amazing. But I also think we have to approach it and say, like, we're a piece of the puzzle or not the whole, we're not the whole pie.
Right, right.
And at the end of the day, like, it's really about the patient. That should be our goal. So I loved how you summarized that. And that's what I kept hearing when you were talking is like, it's just the way that we respect one another. We communicate well, we work for the same goal. And so, yeah, it sounds like your hospital would be a great place to work. So you let us know if that gets open, Brady. Like, we'll advertise.
You got it.
Well, I do want to talk clinical for a few minutes because, well, you've got all of this experience and you've got a brain that we're ready to pick. So clinical for a few minutes.
Sure.
Okay. Patient assessment, clinical red flags. Here we go. What do you think matters most in the first hours of trauma care? And then the other side to that question is how can nurses strengthen their critical care thinking in those fast-moving moments and those, honestly, those evolving situations where trauma patients just seem to be okay 1 minute and then they're not great and then they get worse. So what are those red flags? And then how can we better assess or critically think through those moments so quickly?
Sure, sure. I love this question. I think I always take it back to what we talk a lot about surrounding the TCRN in that, if my EMS team can call and say one thing because they have that 1% battery life left, it's just that mechanism of injury. And that's what helps us on the inpatient side or the acute care side start building that index of suspicion. So we're already thinking, fall from 20 feet, roll over motor vehicle crash, restrained or unrestrained, penetrating versus blunt trauma. So we can start building that differential. And then I think we really have got to find ourselves back to really hands-on assessing that patient. Are they breathing and what does their breath pattern look like? Are they breathing fast? Are they breathing slow? Is it really all over the place? Do they have pulses? Is their skin normal for ethnicity? Is it warm? Is it cool? In not just those distracting injuries of that partially amputated left lower extremity, but even just the subtle signs of, their arms feel pretty warm, but their legs are pretty cool, but they were never outside. So how could it be hypothermia kind of a deal? And that's all even before we just get into that really true overall head to toe assessment. But I don't think enough can really be put on that the ABCs of the airway, breathing, circulation, and that the subtle signs of their heart rate's picking up, their heart rate is slowing down. They were talking and seemed okay when they first got here. And now, like, I feel like they can barely finish a sentence. Like, what is blossoming underneath that skin that I can't see? And I think I get an appreciation for this more and more every year as part of my summer teaching. It's teaching physical exam and really going to that foundational layer of what we learn in nursing school and just taking it one step further as that advanced practice nurse. And I learn something new every year of really how much you can determine without any diagnostics altogether. I think we're lucky now because we have the fast exam, we're getting patients on the monitor quicker, the x-ray, door to CT scan, but we try to really teach and learn that those diagnostics should almost confirm what your suspicion is, not really, well, let's just get all of the imaging first and then kind of figure out what we think may or may not be there. So just really honing in on those skills. But to me, like, we start to have changes in respiratory pattern, the skin temperature doesn't seem right. Maybe once they come up to me in the ICU, the urine output's starting to change. They're getting more tachycardic. Their blood pressure's starting to drop or is persistently high. I'm starting to think, did we miss something, or is this maybe that pulmonary contusion that we know we had that's now continuing to blossom? And are we going from room air to fluid ARDS in the next 6 to 8 hours there? For teaching nurses, it's really utilizing those physical exam skills. And then also, as you progress in nursing and you evolve, I think you have to continuously kind of going back to being self-aware of your own reactions and emotions to situations, and then that situational awareness too. And I think a lot of that can be that first time that person rolls in the trauma bay, it might be an overwhelming experience, or comes into the ICU and codes on you from there. But then giving the grace to others who haven't had that experience yet. Because I think sometimes it can be, well, they acted like they didn't know what they were doing, or, we didn't hear this or that. But trying to move it from you've grasped that competence to then teaching others, because when you're able to teach it to somebody else, that really reinforces for yourself your competence and skill set. And I think also just listening and learning, assigning those clear roles, relaying your assessment findings, in taking the autonomy that the lung sounds are now diminished, or the breathing pattern has just really changed, or I felt like when they came up here, I really had good DP pulses, and now the femoral pulse doesn't seem so great. And even if it's for someone else to come in, or, you get another co-nurse to validate, or you're calling a provider from the team to just say, hey, I just want to make you aware. It's never a bad thing to speak up and express your concerns for what you have going on with the patient. But I think those subtle changes, especially, Holly, like you mentioned, those trauma patients, they're fine 1 minute and they're not the next. And that's where I try to step in, is the advanced practice role. Like, hey, this person has rib fractures. I know it's only 2 rib fractures. I know they're pulling 1,700 on their incentive. And this seems a little silly that they're coming to the intensive care unit, but it's that 6 to 48-hour window that we're really concerned about those contusions blossoming. So we got to stay on pain control. We got to watch their intake just in case things get worse. But if you notice a change in breathing, if their oxygen requirements start to increase, I want to know sooner than later when that's happening, so that we can try to triage and figure out the differential of the problem.
Brady, I think we can dive into that whole topic for a couple more hours. So I hope you have enough to drink and that you have plenty of time so we can jump into it. But, I think just listening to you, those are a lot of the same things that I have found over the years to be huge priorities that are often overlooked. And, I had a preceptor of mine tell me one time that you can't recognize abnormal lung sounds unless you listen to normal ones all the time. And you can't
Mhm.
recognize abnormal heart tones unless you listen to normal heart tones. And so, all of these things about constantly being in tune with the patient and listening. And so many times that patients will come in to the ED specifically, and all of a sudden there's this massive list of orders. And I'm like, wondering, has anybody even seen this patient? Have we and I know this happens a lot in a lot of areas. It's not specific to one, but oftentimes we just kind of throw things at somebody and hope that we'll find an answer for them, rather than the first thing doing is just going in and doing a really, really thorough head to toe assessment, and then complementing that with diagnostics. And so I like what you said about all of those topics. And I think encouraging other nurses to be involved with their patients as well and looking for those subtle signs is extremely valuable. And especially that forward thinking, like you mentioned with the rib fractures. You also talked
Mhm.
about blood pressure being up, down. And I think one of the things that concerns a lot of people are those subtle signs that we hear about. Or somebody can bleed out their entire blood volume into their pelvis and you'll never know it. Or a kid can
Mhm.
compensate their entire life and then just in 1 second they'll crash and die on you and you just won't know it. And mentioning these things that seem like they're here 1 second, gone the next, and not talking about the signs that actually are present and leading up to it. And some of those signs are also evident with spinal cord injury. And I know that's another topic that you like to talk about. But that's another one that kind of gets lumped in this odd category because spinal shock or distributive shock or different types of neurogenic shock related to spinal cord injuries. And people think, oh, this just doesn't match the typical picture. Maybe their skin isn't the same or their vital signs aren't what I expect. And so there's a little bit of hesitancy sometimes with those neuro patients. So, what are some of the interventions that you think are really valuable for those? And it may be not even a shock case, but there's been different studies over time that says put them flat, put them at 30 degrees, all these different things. And so sometimes it can just get a little overwhelming, I think, with patients with neuro issues or even traumatic spinal cord issues of how do we protect their neurofunction? How can we provide better outcomes for these patients when It just seems to be such a complex issue for so many people.
Yes, I agree. And especially if, you're either new to the neuro realm or on occasion we get that nurse that's pulled from, say, cardiac surgery because they're the ICU nurse and we needed somebody to help with the beds for the day. But with the previous topic and even this now, it's not only the snapshot of this is what's changed right now, but it's really going back to trending, understanding what was their assessment in the field, what was that initial assessment in the trauma bay, and then wherever their disposition is from there, and these frequent neurological exams are occurring, whether it's an NIH stroke scale because of a huge head bleed or a spinal cord exam of being able to follow commands and movement in their extremities and strength, is that trying to figure out where they were, where they're at now, and then again when those subtle changes happen. So just being, I think initially well versed on how to complete those exams. We are, I don't know if the best word is lucky, but when they get to my realm, majority of the time I have the imaging to confirm where we think the problem is. And then from there, understanding the physiology. So if I have someone with a high spinal cord injury that's not intubated, we all can say in our sleep 3, 4, 5, keep the diaphragm alive. But it's not just the diaphragm, right? It's your intercostal muscles. It's your whole body at that point that's helping support that respiratory cycle. If it's a lower spinal cord injury, and they still have control in their uppers, being sure that they're careful in their movement, especially if we have that unstable fracture of the spine, in that things could get worse from a neurological standpoint if there's cord edema or that bone then moves to the cord. So for me, it's the frequent assessments and notifying us as soon as possible if something has changed. It's making sure that we're maintaining an adequate blood pressure, and we try to drive our maps up sometimes to 70 to 80 or even to 90, so we can ensure that if we take that map and we minus it from the pressure that's in that intrathecal space or around the spinal cord, that the map is still greater than 65 to ensure that we're getting good perfusion. It's that change in respiratory pattern. So if they're not intubated, how soon is it going to be until we intubate them? Or if they're already intubated, am I concerned about a change with synchrony with the ventilator? And even early on, what turns in from an acute to a chronic problem is bowel and bladder management, because those are usually huge drivers of autonomic dysreflexia, where the patient's blood pressure is going to sky through the roof. They're eventually going to get bradycardic because their aorta is so tight. The heart is like, I got to be able to start getting some blood out to the rest of the body. And that could be there's 2 liters in the bladder, we straight cath them, and all of those symptoms go away. So I think really, early on is just those frequent assessments and those changes. And then as you move to that acute on chronic phase, which I would say once you're out of surgery and kind of starting on your rehabilitation process from there, is 2 key sides there. It's the physiological aspects. So the turning, the feeding, the respiratory care, the bowel and bladder management, the blood pressure control. But there's a super duper large, I almost want to argue, larger aspect of the psychosocial care of these patients, because they may be somebody who was 100% independent and not 100% dependent on you, because they have a bubble of spit on their lip that they can't get off and it's irritating them, or you're trying to wean them from the ventilator and they can't seem to catch their breath because they don't feel those intercostal muscles and that diaphragm helping support their breathing. And I don't think there's anyone that's cared for a spinal cord patient that hasn't said at one point in time they've become a little trying. But it's really, that's where you have your team effort and your support system there, that they just need that extra support right then and there. And I think that is, if their psychological needs aren't being met, which might not totally be there. Sometimes it's like pain, right? We tell our patients, we're never going to take it to a 0 out of 10, but we got to get it to a point that it's manageable. And that can be the same. Like, I can't sit in here for 12 hours, but I want to come back here and check on you. Maybe it'll be every 30 minutes. Maybe it'll be every 15 minutes, every 1 hour. But I think as we work with those patients and through that relationship, they start to trust the process a little bit more. And get themselves to a mindset of they're ready for rehab.
What great advice, not only from the clinical sides of like things to notice or put on your radar or based upon mechanism of injury, diagnosis, what should we be looking for as nurses? But then also, I loved how you tied in the psychosocial aspect of trauma care, injury, and just healthcare in general. Because I think, to your point, we oftentimes see the injury and feel like that needs all of our skills and experience. We got to, really focus on that. But the truth is, we have this whole other side to the patient, which is their mind, their will, their emotions. And oftentimes, if we only treat their physical bodies and we neglect to even address the other, we are never going to get very far. But if you address like that psychosocial, you bring in family context, you get the support, you can really influence how someone feels about that injury and whether they have a positive outlook where they feel like, hey, I can continue to live with this, or the opposite. And a lot of it is just that mental aspect to trauma care, which I'm glad that you not only recognize it, but that you're actively working to address that with your patients. Because again, I think that does sometimes get lost. And in nursing school, we talked a bit about, talking to the patients about their feelings, but I can say that was a minutia in comparison to physical assessment and skills. So communication, and then even just starting those conversations, to your point, I think that makes a huge difference. So we've talked
Absolutely.
a lot. We've talked a lot, Brady. Like, I mean, and we could stay. I feel like there are probably 10 other topics that Michael and I could come up with very quickly to pick your brain about. So, we may have to
Absolutely.
have.
Are you ready, Brady? Let's do it now.
Let's do it.
You thought rapid fire was going to be about your personal. It's not. It's all clinical.
Yeah.
Just kidding. We won't do that to you on this podcast, but maybe a follow-up will be in order. But I was
Yes.
thinking to ask you just so there are nurses at the bedside right now who will be listening to this podcast and they're toying with the idea of advanced practice roles. Maybe they just want to deepen their trauma experience. So maybe going into a different unit, trying out, the ICU, critical care setting. Or maybe they want to do that advanced practice. They may be contemplating all of the above. But what skills, certifications, or experiences do you believe in your experience and what you've kind of seen even from colleagues that are most valuable for that long-term growth in trauma and the critical care setting itself?
I think exposure. You enter the role, it's probably a year or two to really start gaining that true competence and then seeing what else is out there. I started going to national conferences to kind of see what were people doing in other places, because sometimes we can find ourselves in that bubble of, well, this is what we do at my hospital and patients seem to do well, so this is the only way to do things. And you just see so many different ways to run the same race and get to the finish line in the same way, but maybe your course was a little bit different. I think additionally, I'm certified as a critical care nurse. I'm certified with my TCRN. I think both of those, I accepted the challenge of going for those certifications. I enjoyed studying and learning more of that in-depth knowledge and then really practicing that on a daily basis to better understand, putting that knowledge to the test. Do I really understand the difference in why we chose norepinephrine for this patient versus epinephrine based off of their problems or maybe the physiology that I've kind of gleaned from the chart there? I think also going back to just being a good listener and an active presence on the unit, like put the phone down, pay attention to what's going on, listen in to other cases of what's happening, and just being there and focused on what's happening at the job, because you can learn something every day. I don't ever feel that there's a role that, well, I've done this for X number of years. There isn't anything I haven't seen. And you could see 100 rib fracture cases, but there could be one that's different. And with that skill set that you develop, you may be more in tune to those changes, but it's still an opportunity to learn from there. If you want to grow yourself either way, though, ask. Ask people who have done it. Find mentors that want to help and support you. If you're looking into advanced practice roles, I can't say enough about shadowing, because as a nurse practitioner, for example, there's an acute care, there's primary care, there's adult, there's pediatric, there's family, there's neonatal, there's psych mental health. All of those might sound like where you want to be, but you go shadow someone and you're like, that looked like what I wanted to do or sounded like it, but now that I'm seeing it, that's not for me. Or you might be like, I never even thought about this for a career. This is so awesome. This is exactly what I want to do. And you'll learn too that a lot of people have taken different pathways to get where they're at, and always listening and getting advice from them like, well, what did you do? Why did you choose this school? Why did you choose this type of program? What was it about this role? I would say from an acute care nurse practitioner side, you could shadow 10 different people, like five of them, dislike what five of them do. So it's really about finding your niche, but either way, you got one life to live, right? If there's something that you're interested or you think you want to try out, go investigate it, figure it out. Maybe you're like, I've had enough of trauma. I want to do cardiac surgery. Maybe you're doing cardiac surgery and you're like, the trauma population sounds really cool. I want to give it a whirl. Or I've been comfortable as an ICU nurse. I think I want to try the emergency department and meet people with no diagnostics or information and learn how to navigate a differential from there. But that's the blessing I think that we have in nursing, right? It's not only lifelong learning, but our RN license is oftentimes that minimal requirement for us to branch out and gain new experiences, whether it's within your own facility or nationally or even internationally.
Well, Brady, I think you responded to that excellently. And I think you also did an excellent job of setting up a segue for me. So I will jump straight into it. With you talking about all the branches that somebody can take and the various ways that somebody's career can go in nursing. Obviously, yours has gone certain ways, and many people have been a part of that. But, one thing that we love to ask people on this podcast is if there's any particular moment in your career that you can look back on and see where that really pivoted what you were doing or the trajectory you were going down, or any particular person that maybe just had a real impact on your career and has gotten you to the place you are today. Because it's not often that we get to speak with somebody that's a nurse practitioner, a clinical nurse specialist, has their doctorate, has multiple certifications. You have a lot to be
Oh
proud
gosh, oh gosh.
of. So who's helped you get to where you are today, Brady?
Yeah, the sentimental moment. Let me grab my tissues here. I would say first, I want to just really thank Dr. Scott Gunn. He's been my medical director in my trauma ICUs since I started. And he's just always someone that's believed in me and he's wanted to help me grow. He is always willing to say yes to my initiatives, no matter how crazy or extreme they are. I think he really sees my desire to improve patient care, the hospital experience, to enhance education for both nurses and providers alike. He helped me with my DNP thesis, was a great support system there, and just always willing to this day, 15 years later, that if I reach out or we share an office when I'm clinical, to be like, hey, Scott, I'm thinking about this, it's like, all right, let's do it. Other than that, Betsy George, Darlene Lavasic, Michelle Bercheski, and Patricia Tuitt, they are all nurses that I've worked with for almost all of my nursing career that have just been really key pillars of, I think they saw something special in me and wanted to help me advance in any aspect. Whether it was involved in hospital-based committees, evidence-based practice projects, through my education at Pitt, they all have served and continue to serve as mentors, even if at this point, with some of them retired, to just grab breakfast and be like, I'm thinking about this. I need to poke your PhD brain, or I need to poke your experience of 30 plus years on things that I'm thinking about and how we can make it better. So they continue to celebrate achievements for me. I feel like there are some of the people that I text right away if I win an award, or even, with doing this podcast, like, hey, I have this opportunity now. And I'm always making sure to reach out and thank them, because I truly do believe if they wouldn't have kind of taken me under their wings, I would be nowhere near where I am today.
I love that question. I love your answer. I often tell people if you feel like you're where you're meant to be, I truly believe you would have gotten here at a point in your life. But when you have people who support you, who cheerlead you, who your tribe, your village, the ones who are like, yeah, you can do it. we tend to get there faster than maybe we ever would on our own. And so it's not that I don't think you would have gotten to where you are, Brady, because, obviously you have it inside of you to do. But I think having those key supporters and those individuals who rally around you and who allow you to bounce things off of them and their experience kind of help you navigate things and find maybe a more direct route. I think what it does is it then accelerates our ability to accomplish things when we do it with other people. So I love hearing that. It always makes me just, I don't know. I don't know these people personally, but I'm just so proud for them because I know you. And I'm like, man, he was a worthwhile investment, you guys. Well done. You picked a great one to invest in because Brady is out here doing amazing things. So thank you for sharing that with us. Now, I do get the chance to ask you a few rapid fire questions, and this one's
Dun,
going to be
dun,
kind of fun. I
dun.
know this one's going to be fun though, because I'm curious because you're doing a lot of different things. You have multiple roles, but what would you do or be doing if you were not in your current role, like a role, career, job, something that you have considered? It could be outside of nursing. It could be anything. What would you do?
I think it would be totally fun. Like I have a couple of vacations this year, and these people who like video blog, they go on a cruise and they just like record everything and what to do and share their advice. I mean, so 2026 of a job choice, right? But I'm like, this seems like fun, especially if you do that and then the cruise company is like, hey, want to try this new ship? Be like, yeah, let's do it.
Brady, I honestly don't think this is a stretch for you. I feel like this is something that you should be trying to do. And
Yeah.
so I'll be looking for that video posting of your upcoming cruise soon. So yeah, you'd be great at it. I love that. I see it. All right, I have some categories regarding favorites. So first up,
Okay.
favorite book or maybe a quote that just really inspires you.
My quote is from Gandhi, the be the change you wish to see in the world. I have it as a magnet, a coffee cup, and I feel like it's one of those things like if I need to recenter a minute and I think about all the things I'm doing, it's that. That's my driver.
I love that quote. It is honestly one of my favorites. I think my mom, she probably didn't know she was quoting something similar to Gandhi, but she would say, if you see a problem, oftentimes you're meant to be part of the solution. I think sometimes it just kind of goes hand in hand. It's like sometimes you have to be the solution that you're looking for. So I love that. Okay, do you have a movie, TV show, something binge worthy that you would like us to recommend us to put on our list?
I mean, I'm a huge Bravo fan, so Housewives all day, every day. Any franchise, doesn't matter.
Oh, I love that. Sometimes I do fall into the well of different reality shows. It doesn't happen often. Sometimes it's if I'm feeling under the weather and I need something that is I can drift off to sleep. Yes, I
Hmm.
agree. And it doesn't really matter to me which one it is because oftentimes I'm like, yeah, yeah, I saw your character on a different one, but you're back again. You're in Nashville now. But I love that. Okay, maybe a musical artist, favorite song, something that can just move you.
I think Britney Spears is a solid favorite for me.
Let's go. Free Britney. Okay.
Yes, yes,
Ah, I
yes.
mean, I'll
She's
be
never
honest.
performing in the States again, she says, but that's okay. We'll travel. Maybe I'll video blog that for the first time, huh?
Absolutely. If you do go and see her, we would like that must be a video blog, 100%. It will probably go viral for many reasons.
Yeah,
But yeah, but
whatever it takes.
oh yeah, right. Exactly. I'll repost for sure. Okay. Speaking of which, if our audience wants to follow you online, is there a social media platform that we could do that on?
I'm on LinkedIn, yes. First and last name.
Amazing. I will put that in the blog for this episode. So thanks for sharing that. And thanks for answering all of my rapid fire questions. We just like to get to know you a little better. So thank you so much. We appreciate it.
Thank you both.
Well, Brady, it's been great getting to chat with you today. And like I mentioned at the beginning, I've known you for quite a while now, and you've been active in the TCRN practice exam item writing group, and you've, been to the office several times before, and just a great part of that group. And it's always a pleasure meeting with you, but to get to sit down and just talk one-on-one and chat about the things that interest you and learn more about your career, it's been really a wonderful time. So thank you for sharing with us today. We appreciate it.
Absolutely.
Well, Brady, I want to thank you for spending time with us on BC and Friends. The way you speak about trauma care underscores the depth of knowledge, skill, and collaboration it takes across the entire healthcare team. Your work reminds us why excellence matters, helping patients and families find healing and hope after life-changing injury. That's our goal, and we appreciate all that you do. That'll be a wrap for this episode of BCN and Friends. Don't miss what's next. You can subscribe, share, and join the conversation by scanning the QR code for Learn updates in this episode blog. You've got a topic you'd like us to cover? You can drop us a line at bcn@bcn.org. I'm Holly Briggs with Michael Dexter, and we're proud to celebrate your dedication to nursing across the emergency spectrum. Until next time, stay curious, stay connected, and we're out.